and I'm just going to talk to you a little bit about trauma. I've kept this talk fairly generic, as in themes in trauma, rather than specifics about what to do in certain circumstances, but clearly there have been lots of questions posed about specifics, and I think I'll rattle through this as my plan, and then talk to anyone who has specific questions and also challenges about what I'm saying and what I'm envisaging as a system. And I see this very much as a dialogue with anything I show you as really hopefully a spur to increasing the questions. I notice that it is quite a mixed level of experience and diversity of approaches to all of the themes that are going to come up. So if you ask me as a trauma surgeon, what do I see as the BNSSG trauma? I'm going to be very hospital focused, hospital biased, which is North Bristol where I work. That is a major trauma centre that serves a population of around 2 million, just under 2 million, with about 1,600 or more multiply injured people per year arriving here for their treatment. And that's from across the Severn region. We also have a large community population serving, depending on where you draw the geographical boundaries, about 800,000, and that translates to around 600 hip fractures per year. Why do I say hip fractures? Because it's the easiest thing we measure, it's very accurate, and it gives us an idea, a benchmark of the level of other fractures we see, such as ankles, wrists, tibial fractures, etc. And level of busyness. If we look at the other hospitals, they're very similarly busy. The Bristol Royal Infirmary has about 400 hip fractures per year, and Western General about 300 hip fractures per year, with all the trauma associated with them. They just don't have the major trauma coming in, although they have other specialist services. But clearly that's not the whole picture. And if you're looking at trauma, really, you have to include the minor injury unit, who see a huge number of patients. There's a minor injury attached to the ED in all of the hospitals, but also freestanding, South Bristol, Clevedon and Yate being the ones that I deal with. And then outside of this, and I notice there's GPs on the call as well, GP surgeries, and you see a lot of ambulatory trauma there, and it makes up a lot. So for instance, 75% of knee pain gets managed self-managed. Of that, about 25-30% comes to the GP practice, who again manage the majority of that without referral to secondary services. And the same applies for other types of trauma, and we'll talk a little bit about the risk around that. What do we see as trauma? Is this trauma where we have that polytraumatized patient, multiple injuries, arriving or helicoptered in, mainly helicoptered these days, clearly to avoid the ambulance queue. But is that trauma, or is this trauma, which should be more in keeping with what you might do at home? Because it is, and for that person, it may be a major trauma for them, and we should bear that in mind when we discuss trauma. What we see here is a certain population. What's seen in the minor injury units is a different population, perhaps, and what's seen in GP surgeries or in the community self-managing is again another population, but they have common elements, and that's what we'll draw out. Again, specifics of fractures, you see there's a nice red arrow here telling you that that is broken in that area. So what happens to this fracture? Well, this doesn't need anything specific. It doesn't even need a boot. It just needs to be managed with pain alone. I said I wasn't going to get into fractures, but I'm using this as an example to say, what does that mean? So it doesn't need anything, but you're seeing it as a person who's first seeing this. How do you advise that person? What do you tell them? What expectations do you lay, and how do you address their fears from this? And the easy bit is the ankle fracture itself, which has a nice arrow pointing to it, but longer term the osteochondral defect may become more of an issue for this particular person, or may have predated the ankle fracture itself, which then again tells its own story. Likewise, fifth metatarsal fractures, fracture at the base here, do these need to come to a fracture clinic? Do these need further onward referrals? No is the answer on the whole, but that doesn't mean to say they don't need specific advice. It doesn't mean to say they don't have specific fears that need to be allayed, and also levels of expectation that they will have because they know someone who's had a fracture that need to be addressed, and also, you know, it's not going to be better in 2 weeks, it's not going to be better in 3 months, it's still going to be painful. As long as they know that, they're probably fine to self-manage, But if someone has said that it's going to be better in 2 weeks and they should be running by 6 weeks, then they're clearly going to think something's particularly wrong with their fracture. And all of those things become very important. Which is the worst injury in the longer term? This is clearly a very smashed fracture. Is that a worse injury than the following, than the ones above it? In some respects, it's a more devastating, higher energy injury, but the important thing is how that patient is managed, what they are told, what their expectations are, and the rehabilitation program. And that's really what I'm going to focus on, because all of us in this call have that responsibility. So what does BNSSG trauma look like? It looks like all of us contributing to a system and being roughly on the same page, and using our specific skill sets to try and get that person treated as effectively as possible. And how do we do that? We're worried about consenting issues, and the reason I put this up is because this is the latest edition of the GMC standards published in November, applying predominantly to the doctors among us. But what it really highlights is the move towards shared decision making. So we're all guilty in healthcare services of taking ownership of someone else's problem. I will treat your heart attack. I will treat your angina. It's now my problem. I'm dealing with their angina, and they park it very much in our surgeries or in our clinics. Same with fractures, same with any skeletal injuries. But actually that person has a lot of attitudes that affect their eventual outcome, and actually they need to be the ones leading the discussion, making the decisions, and the ones driving care. So part of that is then scans don't make people better. So should we have access in all of our clinics and minor injury unit to three-dimensional scanning? Well, it doesn't address necessarily their problem. Might be they're worried that ankle fracture means they're never going to play football again. The fifth metatarsal fracture, that they can't go hiking again on their holidays. And actually no scans will change that, other than if you've spent enough time talking to them to say, well, what are your actual fears? Do you know what? You can go on your hike. It is going to hurt, but you're not going to damage it. And therefore you can at least enjoy some of it. Maybe not to the extent you would have if you hadn't been injured, but you don't need a CT scan or further scans. So you don't need any fancy imaging to do that. Similarly, waiting lists don't make you better. It doesn't necessarily apply to trauma, although we do sometimes have to put people on a cold type pathway, but the same applies for, and I do knee and hip arthroplasty. You feel this, people have this a relief when they're added to that waiting list. They know it's a year long, they know it's now getting out to 2 years long in some circumstances, but they suddenly feel like, whoa, thank goodness something's happened. But really nothing's happened, nothing has changed, and there's a conversation that needs to happen around what they then do to treat themselves while waiting for something else to happen, and they may well self-treat fully and then not require something else to happen down the line, even with fairly advanced conditions across the specialties. Similarly, physiotherapy, and I hate this, there's lots of physios in the call, they're going to clearly want to lynch me after this. Physiotherapy referrals don't make you better. So there's no point in saying, oh, you have a painful ankle, it's very stiff and won't move, I'll just send you to physio and they'll look after you from here. That's not going to make that person better. That's a missed opportunity. So the wait for physiotherapy referrals in the community, you know as well as I do, is massive. The ability to see that person and supervise them to the extent that would be the absolute ideal, particularly in that person's view, is not present. And therefore it's not the panacea. That contact is an important part of everything that's available through trauma. And that's where I come back to, we're all responsible for trauma. Surgeons, and this is me, we don't make people better. There are certain circumstances where I have to do an operation in order to facilitate them getting better in a more predictable fashion. But a lot of times, probably over 75% of the people I see, it's more a reassurance that that isn't required and that they do just get better by themselves and they need to take charge of that. And occasionally you refer to other services such as physiotherapy, but on the whole, and my practice in particular, a lot of practices are getting that way, is to move people towards much more self-directed and they take charge of their recovery program. And what is the biggest challenge, therefore, that we all have in common? catastrophization. And that's where the first contact becomes extremely important, because if that contact is, ooh, that's a bad one, then unfortunately we set off a train of events that lead to potentially negative outcomes being more of a likely than less likely. If we say, oh, you have broken that and that needs an operation, now that might just be the porter pushing them to their x-ray, says, oh, you're definitely going to need an operation in that. You'd be surprised how fixed that idea can become at a very early stage. And even if I then can't see a fracture, let alone one that needs operating on, it can be difficult to move that, and that person feel like they're not having the best care available. Equally, when they have an injury, it changes their life perceptions. And this has been catalogued in many specialties, but in orthopedic trauma by David Ring in Boston. And it's a real thing. It's a massive thing. And when we use that contact, whatever contact that is, to deal with this perception that that's it, that their life's over, then things get a lot better a lot more quickly. And there's very, very simple things we can do in that. We've learned a lot about this from dealing with hip fractures. Most people who have a hip fracture, when you measure their quality of life assessment the day of or day after their hip fracture, it actually comes out as worse than death, because that's how they feel. They feel that that's it, that they have broken their hip, and they know people who've broken their hip and not survived, and they feel that that's their innings and they're just not going to get over this. So it's important to learn from that. Yes, that's an extreme. In an ankle fracture, you'd be surprised when you actually drill down to it how many of the ankle fractures that are persistently problematic are to do with that catastrophization, that something terrible is happening and that their ankle is just grinding to dust underneath them, because that's what it feels like. So one of the questions that came up were, what are the complex trauma pathways, what availability of urgent MSK pathways, particularly non-fractures, fragility pathways, hip fracture pathways. So all of these are in some level of existence. Complex trauma pathways, it's usually from point of contact, so within the hospital generated and resource dependent, but most of them where they have fractures have an access back to myself and Andy Riddick. Where they have other trauma, so general surgery, head injury, spinal traumas, there's less defined pathways. When they have specific rehabilitation needs, we do have rehabilitation doctors, but that's really a service in its fledgling state and not as good as one would hope. Similarly, with the question that come up a lot as well, the psychological pathways, we have a psychologist here and they see a lot of the patients acutely, but so far we've not been able to get enough resource, and that's really just the appropriate person to come and run clinics. And there is a need, and that need unfortunately remains a burden on community services. There's access to fragility pathways mainly for investigations and treatment, and in some respects with the falls systems and the fracture liaison services, we're getting better at identifying the fractures and medicating, but that's only part of the pathway. The other part of the pathway that's lacking is that rehabilitation and the ongoing processes, particularly pushing them in a self-motivated or self-directed manner. But one pathway that's the most important problem, and pathways can look like this. If you've all those pathways on your wall, it's like, where do you send this person? Well, by the time you've got the blue dot through the green zone at the end, you've kind of lost the will to live, I would suggest. But what's common in everything is the conservative management pathways. What does that mean? So conservative management can mean anything from, you just don't need an operation, everything's going to recover by itself, you should be fine, off you go, to a proper, here's how you actively recover that. And I would strongly advocate that it should be more of the latter than the former if you don't want that person to reattend. If they just assume that everything's going to get better by itself, then my experience of that assumption is that things never recover fully, and although they may self-manage for a while, it's usually with the decreased activity levels and all that goes with that, and eventually representing in other formats. So this is not just me being all woke and empowerment. It's actually a real life thing where if you just talk a little bit longer to your patients, and I'm aware that GPs are going, I can talk to patients longer, right? What world are you living in? But we have the same in fracture clinic. We had a 60, 70 patient fracture clinic yesterday afternoon. But extra few minutes, yes, we ran until 6, we're supposed to finish at 4. But that extra few minutes per person means they don't necessarily represent that they are going to walk better and function better, one would hope, and they don't always enjoy that few minutes, as we'll come to that later on, but at least they understand their fracture, they understand what I require of them, what my perception of how this recovers is, and they can work to that plan. And I'm clear when they leave that they actually see what I see in terms of their trajectory and have a safety net of them that if it's not going according to that plan, they can come back. Now, challenge will be, that's easy for me. I've been doing trauma as a specialist for over 15 years now. So how does someone else do that? And there are methods of doing that which need to be just bred into every single service. So in terms of, again, dealing with the questions, I've dealt with some of these. What services do we actually have available? Well, the main one for trauma is going to be the fracture clinic services. Now, at North Bristol, we run a next day fracture clinic for all injuries seen, or as close to it as we can get, and it's not foolproof, as many of you will know. But we try and see them in person the following day, or as close to that as we can, give them that advice up front and get everything moving at that juncture. A lot of times it's a one-stop clinic, so they don't need to come back, but we do a safety net with an open appointment system. The other services, they run hot clinics, which is a telephone triage type system, which has pluses and minuses. It saves the patients a trip to hospital. They can get the advice they require through that system, but it tends to try to become a little bit more of a generic system, and so that's why we don't favour it at North Bristol. But that's not to say it can't work in the other centres. Urgent care services, particularly non-fracture, are kind of in infancy really. The acute knee service is there for those presenting with an acute knee trauma, but unfortunately everything becomes acute knee and chronic issues at this time because of everything that's happened with COVID. And so that is a pretty overrun service and difficult to access. We are trying to get urgent advice networks up and running, so guidance, so that, for instance, GPs or practitioners in the community can ring up and get real-time guidance on people that they're seeing, if not the same time they're seeing them, very close to that. Rehabilitation across the country, that is the biggest unmet need of any trauma. And what that looks like now in real terms is that it has to be self-directed. And really what we need to be putting in place is the infrastructure to get that person doing it confidently themselves. And actually, like many things and across specialties, if people aren't willing to do it themselves, then there's no service you can put in that will absolutely get them back to what they were before. And many times, even with trauma, getting them back to where they were before is no good, because they broke something, they went over on their ankle, and that pointed to something that was underlying all of that. And psychology is the manpower for psychology is again a massively unmet need. Mental health services in general, but around trauma with post-traumatic stress, it's when it's there, it's great, but it's definitely not. There's not enough of it to catch everybody who needs it. So navigation-wise, what does it look like? We've got our major trauma pathways, our community trauma pathways. In North Bristol, I've tended to, as the lead there, I've always blended these so that one learns from the others. So what we learn from our hip fractures, we translate to our major trauma patients, because if you can recover a hip fracture at the age of 88 or 90, that's the same sort of drive you require to recover from a polytrauma, regardless of how many injuries you have. And actually, it really does work both ways. And the elderly population, the frail population, really do inform fracture care right across the spectrum of that. So here's someone who's polytraumatized. We will fix all these bones up, and there's a tibial fracture even further down, but it hadn't enough space. You can see pretty smashed humerus, hip fracture, a femoral fracture, a tibial fracture. And guess what? they're going to pop up in your GP surgery. They're going to pop up in your clinic. They're going to pop up at the minor injury unit because they're worried about pain. And how do you deal with that? And that becomes really important. That's the first contact. The reason they've popped up is some other part of the service has failed, or their expectations have been met, or they've been safety net to say, if these things happen, contact your local services. Again, easy for me to sit in the ivory tower of a major trauma centre and say that that's not a difficult problem to deal with, but there are common themes that come out, and the most common theme being that every pain means that it's gone terribly wrong and everything's going to fall apart again. They're going to be worse than they were before. And these are often people who've lost their livelihood and certainly lost their lifestyle in terms of that. And it carries across, whether it be knee arthritis, hip arthritis, ankle. The theme basically is never under any circumstances do you say certain things. What's the worst advice I've ever heard? So never under any circumstances do you say, let them limp. So you never let them leave your sight limping. And that will treat the vast majority of all that I've just shown you and talked about. How do you do that? How do you tell someone not to limp? I mean, there's lots of experienced practitioners. Who has actually told someone, don't limp, ever? And when I ask that of orthopedic surgeons who are very experienced in trauma, almost nobody has. If I asked that of trainees who've sat in fracture clinic after fracture clinic and seen hundreds of lower limb injuries, none of them have. When you ask them, how do you do that? They don't know. But there's physiotherapists on here who know that. It's like in a heartbeat they can tell someone not to limp. Although with the physiotherapy colleagues on the call, I do disagree about crutch height. So I often elongate that. But essentially you tell someone to keep their shoulders level, never dip their shoulders, never lean forwards, and always walk upright. And if they need walking aids to help achieve that, then that's fine. If they need a Zimmer frame, make it taller so that they're not bent down like a little old person stereotype into their Zimmer frame. So they're walking tall with their head facing the world. And then a lot of things get a lot better. What's the worst advice I've ever heard or continue to hear? Stop. Stop running. Stop doing long walks. Stop doing this. Never tell anyone to stop. If someone who's running, and in fact I'm seeing a colleague this afternoon who's been told to stop running because he has knee arthritis, and it's like, you're a human being, you need to run, that's what you're designed to do. So he'll get a talking to this afternoon. But essentially, pain often in those circumstances is a re-leveling of expectation, but it's not a stop. It's you have to work hard to go back to what you want to do. And if you can get that right at the start of the problem, and often you as practitioners call will be at the start of the problem, change the circumstance in which it's occurring. So most of the time that's about addressing the imbalance, usually one side more stronger than the other, a lack of core strength, a lack of coordination, an altered gait pattern. Then they can get back to some level of their chosen activity. It may not be the ultramarathon they wanted to achieve, but they're at least not stopping. The worst thing I have is the person who stopped exercising a year ago and they come with arthritis to a knee clinic, because restarting that after a year is much more difficult than it would have been initially. So I'm happy to be challenged in that. So as I said, it's easy for me to say all this. I'm sat in the ivory tower with all the security that brings. So how do you manage this risk? So it's much more difficult if you're in a GP surgery and you're seeing someone for 5 minutes and you say, yeah, it's just fine, just walk on that ankle that really hurts and that's probably arthritic, and I haven't got an x-ray yet, but you know, what could possibly go wrong? Well, all kinds of things. So it's a very difficult thing to be in any way confident about. And that is the thing. You've got to gain that confidence about how you specifically manage that, rather than send a referral off, send an x-ray, because the x-ray isn't going to treat them immediately, but there are certain things you could put in place. So we're all responsible for managing the risk, but ultimately the patient, the person in front of you, the client, is responsible for their own joint. So you've got to give them the guidance for that. If they're seeing you and they're relatively fit and active, they've had an acute injury, probably not one that you're going to refer on, how do they start to rehab? They can go in a swimming pool, lots of access locally to leisure centre facilities through various schemes. And essentially it's a non-gravitational thing. They can keep their endurance base while they recover their ankle. If they're told not to limp, for instance, then that'll recover much more quickly. If they need crutches for a couple of weeks while they recover, that fine. But the bottom line is the sooner they get back to a normal gait pattern, regardless of the injury, then the quicker they recover. And ultimately, they've got to be the ones to do that. So how do you measure that? And that's what this is about. And that's what I would advocate from this diverse audience is, it is how do we gain that confidence in our systems? By looking at a referral pattern. So we send it to fracture clinic, by all means, we'll see it. But what happened then? So you need to have some kind of metric that regains that, that educational event back into your system. So did we discharge them? If we discharged them, was that something that could have been done at first contact? And then you and the patient are both much more fulfilled in that consultation. So we'll have some system of checking that. Reattendance. So that might be a safety net, and we see that through the fracture clinics, not uncommonly. Most of the time, by safety netting into an open appointment system, we avoid further reattendances. But if they do reattend, was that avoidable? Was that some reason for that could have been dealt with at the first contact? So again, that the fifth metatarsal fracture, were they told it was going to be better in 6 weeks and they should be able to run around, which was never going to happen because it takes at least 3 to 6 months before it becomes in any way comfortable. And again, that would feed back to educating the system. It's not a criticism of the system, it's just an opportunity to feed back into that system in terms of overall learning. It may not be your system to come back to, and the biggest thing here is where we send people out, and actually what they do is they sit on repeat prescriptions in the GP surgeries because they keep attending, and as GPs, we're not musculoskeletal necessarily trained to the same extent. It's very difficult to do other than say, well, let's try some analgesia, because clearly the hospital consultants are fine, or the therapists are fine with this. And then that may be a system that could be changed. And in particular, if we lay the emphasis for that change on the individual concerned, it's not really healthy for a 30-year-old who used to play football to now be on opiate analgesics, for instance, or requiring these and limping. There's something there that could be changed to put that person back to the lifestyle measures and presumably employment measures that they would like. And again, analgesic requirement, particularly the use of opiates, should almost be red flag in that. For a lot of conditions. Knee arthritis, hip arthritis, I include that. I know that's a hard sell when you're sat in a surgery with very little time, or a therapist with very little time, but equally that time spent may prevent the further reattendances at the other various services, or repeated requests for onward referrals where the opinion comes back as doesn't require an operation, which maybe seems singularly unhelpful. And that's education. So who does it? It's probably the fundament of all of this. How do we get that learning flowing through the entire system? And I have no magic wand on that one. We have set up during COVID, Ollie Pierce ran educational sessions remotely, which were extremely well attended and well thought of, but it seemed to be a one-off. It was a series and it was very good. But even repeating that probably isn't as inclusive as some of the measures I've just talked about, which are just me thinking out loud, really. And we, as people at the sort of other edge of it, i.e. in a tertiary or secondary care service, should be responding to whatever the educational needs are. Because a lot of times that comes back as seemingly critical, or why on earth has this always been referred, etc., etc. And if that is the case, then that's a point of learning rather than a point of criticism, and both systems can learn from that. So that's all I was going to say, and I was hoping that there will be lots of questions, or at least some questions. Otherwise, I'll refer back to those that Sarah has sent through already. So I'll just stop the presentation there.
Great, thank you for that, Mike. That's brilliant. So has anyone got any questions? It normally takes a while before someone says anything. Oh, yeah.
There's a hand up.
Yeah, so Pat, would you like to go ahead?
You think you're still on mute, Pat?
It's not really a question, it's just say thanks for that, Mike. We do get a lot of chronic pain in general practice, and we have over the years There's been a lot of research on that, and we've moved away from prescribing all these opiates and gabapentinoids and everything. It's quite interesting. I think we do have a way to go about perhaps applying what we've learned from chronic pain to acute pain. I don't think necessarily when we see people with hip arthritis or knee pain, I think we are very quick to send them down the pathway, so to speak, expecting somebody to fix them. And I think, yeah, we do necessarily, we've sort of learned a lot, but I think it's really good to hear that you've got the same issues that we have with chronic pain, but with acute injuries and trauma. And yeah, it's a really great, it's like some real food for thought there, Mike. So thanks for that. Yeah,
thank you. It's interesting because, you know, even in the arthroplasty clinic, I mean, again, I'm talking from the ivory tower. I'm fully aware of that. When you say it, you might say exactly the same words in the same order, but because I'm this orthopedic surgeon way up there, they've waited to see for ages, and they've waited for 6 months for the appointment. It seems like when I say it, they seem to say, okay, that's fine then. But a lot of times, you know, a lot of even fairly, you know, advanced arthritis, I successfully managed by just getting them walking better. But it takes time, and you got to see them. As we all move to remote access, it's so difficult to get someone walking better when you can't actually see them walk.
Yeah, and we should be fair to our colleagues in secondary care that, you know, often these people have got lots of comorbidities, and it's a big risk for them having operations. And, you know, we really need to optimize people as best we can before we send them your direction, Mike. Yeah.
Yeah, but we're all guilty of going, yes, arthritis needs a knee, yeah, take knee arthritis, right, off you go on a waiting list. And actually there's a better way. I think there's a better way. Where when it is my relatives, which they get a long talking to with a very thick Northern Irish accent and get scolded an awful lot. So
yeah. Cheers.
Thanks for the comment.
Any other questions? Anyone want to put anything in the chat box or raise your hand? Ooh. Nova, do you want to come on and say your question?
Not really a question. It's just really useful to hear from a trauma orthopedic surgeon that the way ahead is explaining to the patients that they are the ones that are driving this force and they need to get better. Sometimes I felt as if I was a little bit out of my depth by saying, go swimming, get moving, keep moving. Whereas now I've heard from Mike, I feel a lot more confident in giving that advice. That was all really.
Well, thanks for that. I think, yeah, I mean, that's the thing. I hate the word stop. Like, I'm not running because my knee was sore. And I've had that from colleagues where I've just bollocked them. The professor of orthopedics got an absolute bollocking when he limped past my door once. I was taking a patient out to the waiting room and he just got bollocked because it was just atrocious. He's an orthopedic surgeon. He shouldn't be limping. Mind you, my patients get bollocked too. So they were just loving it, the fact that I was just bollocking everybody. That advice, you know, and swimming pools as well, not just swimming. Walking in a swimming pool is a very good thing to do, and that's something we've learned from professional athletes. In fact, we've learned it from professional horse racing as well. That's how you rehab injuries in big, heavy-hitting sports, because you can't do your normal active training. So you use a swimming pool as a way. It's not gravity free, but you can really keep an endurance base. And we forget that not just the limb is sore, but the overall endurance base. And Pat referred to keeping them healthy. If they lose the endurance base, then you've lost a lot of the battle in terms of trying to keep them running, and keep not running as such, but keep them moving, keep their blood pressure under control, keep the diabetes under control, etc. So yeah, please keep them all moving. So someone mentioned about height. What did I say about height? And let me get that comment. Or come on and ask me that. Challenge me on that one.
Go on, Martin. Do you want to ask the question?
No, I don't want to challenge. I just wondered what you were saying.
So I don't know where the guidance comes from in terms of height, and I think it's to do with again that element of risk. Where if I look at the height of crutches, almost now I will take someone's crutches when they walk in, and these are crutches that have been given to them by therapists or trained nurse practitioners, and I will just go up at least 2 notches and hand them back to them, and then walk them. And sometimes, and rightly so, they challenge me as just being a little bit arrogant in doing that. But on the whole, that puts their shoulders high, so they then can't limp. If they're using the crutches close to the body, they then physically have to lift and place their legs, rather than that Trendelenburg or more likely Duchenne's type gait pattern where they drop or lift their hip and swing it through. And I explained to them that that keeps their center of gravity in the center of their body throughout their stride, and show it to them, and it's so effective. And the analogy I use for that is, if I walk into their house and start swinging, open their door and start swinging off it, they throw me out because I'm going to wreck their house. It's going to come off the hinges. And likewise, all the joints in their legs only bend in the frontal plane. They're not designed for rotation. Yes, they accommodate rotation, but they do really, really badly if it's rotation in terms of an antalgic gait. And so everything stays sore. So once I line them up and use that analogy, then and get them higher, their center of gravity higher, it means that they can't lean forwards anymore, they can't lean sideways anymore. But that is an element of risk, because that actually more crouched position probably means they feel less like they're going to fall. And it takes a little bit of confidence and actually it takes a few steps in the clinic, and I don't just tell them to do that, I show them and go through it a few times, and they end up looking far more secure walking out, particularly cornering, when they do that. And that's why I say I raise the crutches almost invariably. Do you agree, disagree, or do you think that's heresy? I think you're muted, Martin.
Oh, you're not on mute, but we can't hear you, Martin. Have you lost sound?
Technology let us down.
Right. There's a comment there from Nova again. Martin's microphone is bust.
I thought you meant me. This mic is bust. Mike Kelly is bust.
Right.
I know.
Yeah, she's just saying that.
Walk normal, walk tall. Yeah, I agree with that. Particularly the slow thing, but also symmetrically. Walk symmetrically. Move your feet exactly the same, rather than, you know, a big stride with your injured limb and then the other one is thrown to the same level with a swivel of the hips and shoulders, is what we commonly see with an antalgic gait. Yeah, so I absolutely agree with what you're saying, Nova. I just basically start shouting at them when they get up from the chair in clinic, and keep shouting at them until they leave. So maybe that's why they don't come back to see me.
Brilliant. Are there any more questions? We've only got 5 minutes left anyway. Oh, yeah, Sinead, do you want to go ahead?
Yeah. So it works in the MSKI team, and so I've got a weird background on, sorry. And I see a lot of patients with plantar fascia or like ankle away that just won't walk properly, and I've given them advice, but they're just telling me they can't walk because they're in too much pain, and they just literally refuse it. They limp up the corridor like a crab, if you know what I mean. And I'm just wondering how you approach that, because it doesn't, like, they're just telling me they can't do something because they're in pain, and they won't rehab at all because they're in pain, and they won't do anything, and you know, they're just. And then they want, I've seen them, I've been here for that long that I've seen them cyclically every 2 years they come back with the same heel problem. They haven't, you know, and then I send them because they want to go somewhere, but it seems pointless to send them to orthopedics because they're not going to do anything, but they won't listen to me. So, you know, apparently know the date of birth and their address because they've been in that often. And it's just, you know, where do you go with them? And, you know. So
again, people have to buy in, and it depends on your interaction with that particular person. But one assurance you can give everybody is continue to limp, and your pain is going to stay bad and probably get a lot worse. If you can normalize your gait patterns, it's your most efficient stride, your most efficient gait, and you're most likely to be able to recover things. Now, if you've got underlying arthritis, it's not going to be a perfect joint, even when it's recovered, but it'll be better than what it is when you see them. So it's their call. You can choose to continue to limp, but I can guarantee you that pain will still be there. And as you said, I'll see you in a year, I'll see you in 2 years, because it's not going away. If you stop limping, you'll start to rehab. And if you start to rehab and get your strength back, particularly your balance strength, then everything else will start to fall into place. And not everyone buys into it. And if it's around the ankle, I'll recommend that they buy a lace-up ankle brace. So now once they've bought it themselves, they've bought into the idea of they're going to walk better. So yes, do I have fancy ankle stirrups and things like that? I do, but actually, particularly those who we give these things out, but do they use them? Well, I guarantee you when they've spent 20 quid on Amazon, they use it a lot more than when I give it to them for free. Not saying I'm withholding resource, but I'm not, those have specific indications and they're not really indicated for that. But ankle braces that you buy yourself, you can do whatever you want with. So it's an adjuvant to getting walking. If they can't walk, then I send them to the swimming pool, put a woggle on and go walking in the swimming pool, because you can't tell me that that impact in the swimming pool is doing something bad to your joint, but you can then at least get fitter, get a little bit more core going. And so whatever they give me, I give them something else that they can definitely do, and they have to choose. And if they choose not to do that, like anything, like any therapy intervention, that's their choice. They can choose whether they stay miserable with their pain or improve themselves, but they have to choose to do it themselves. And that's why I said the scan isn't going to make them better. The physiotherapy isn't going to make them better, because unless that person chooses to engage and takes responsibility for their own body part, symptom, condition, whatever you want to call it, then they're not going to improve with anything. And we see that with knee replacements, where you get a 15% dissatisfaction rate, probably the population you didn't want to engage in the first place. And we don't have any caveats. My colleague, who has the same approach, somebody walked in with an atrocious gait pattern and got an absolute bollock and got straightened up, and was walking much better. And as he's leaving, he goes, "You do realise I've got cerebral palsy, don't you?" And it's like, he did, but he walked much better when he left.
Okay, grand, thank you.
Great. Any last questions? We've only got about 1 minute left anyway, so just double checking anyone's got anything urgent they want to say. No, I don't think so. Well, thank you very much, Mike, for that presentation today, and thank you everybody for attending the education session. I will be sending out a feedback form. If you could fill that in and return it to me, that's very helpful, because it helps us when we set up these sessions. Hopefully there'll be some more to come in the new year, so I'll let everybody know about that. And I think that's it, unless anyone else wants to say anything. I think that's the end of the session. Thank you very much.
Thanks everyone for participating. Thank you.
Thank you.
All feedback welcome.
Thank you. Bye.
Bye.